Subtrochanteric hip fractures. The femur is the longest and strongest tubular bone in the human body and one of the principal load-bearing bones in the lower extremity. The thigh bone has two bony processes on the upper part, the greater and lesser trochanters. The lesser trochanter projects from the base of the femoral neck on the back of the thigh bone. Subtrochanteric hip fracture is a break between the lesser trochanter and the area approximately 5 cm below the lesser trochanter. Femur fractures can cause extensive hemorrhage, with an average loss of 1 liter. Complications and injuries associated with subtrochanteric femur fractures in the adult can be life-threatening and may include internal organ injury, fat embolism, pulmonary embolism, and acute respiratory distress syndrome, ARDS. Fractures of the femur often result from high-energy forces such as motor vehicle collisions or falls from height. In older adults, low-energy falls are the most common cause due to osteoporosis, especially in elderly women. Long-term use of bisphosphonates may increase the risk of rare type of thigh fracture. This injury, known as atypical femoral fracture, is similar to a stress fracture. Industrial accidents and gunshot wounds account for most other femur fractures. Pathologic subtrochanteric femur fractures are uncommon but can occur from bone cysts, metastasis, or, rarely, secondary to primary bone tumors such as osteogenic sarcoma. A femoral subtrochanteric fracture usually causes immediate, severe pain. The patient will not be able to put weight on the injured leg, and it may look deformed, shorter than the other leg and no longer straight. The clinical diagnosis is usually obvious based upon the mechanism and the presence of pain, swelling, bruising, and deformity, including shortening of the thigh. Extensive soft tissue injury and bleeding are common and shock may develop. Because of the high association of femur fractures with other injuries, particularly if high-energy trauma is involved, the patient must be carefully assessed following the basic guidelines of Advanced Trauma Life Support, ATLS. Stabilization of the patient's airway, breathing, and circulation takes priority. Once the patient is stabilized, a thorough secondary survey is performed looking for other major injuries. As part of the secondary survey, the pelvic ring and knee should be inspected. Neurovascular injury caused directly by a femoral shaft fracture is rare. Nevertheless, a careful neurovascular assessment of the affected limb should be performed. Distal pulses should be palpated and sensation and motor function assessed. It is often useful to compare findings to the contralateral limb, assuming it is uninjured. Anterior, posterior, and lateral plane radiographs of the thighs should be obtained when a femur fracture is suspected. Careful radiographic examination in at least 2 planes is necessary to determine the exact site and configuration of the fracture pattern. The management. Pre-hospital personnel should immobilize the extremity in the position it was found. Essential initial management at the hospital consists of evaluating the patient for major injuries and treating them as appropriate. Placing an intravenous catheter and providing analgesia. Patients with open fractures receive antibiotics and tetanus prophylaxis. Your doctor may also give you blood thinners. Non-operative management for these fractures is rarely the treatment course. It is only potentially useful for non-ambulatory, comfort care, or extremely high-risk patients. Conservative treatment involves avoiding stress on the fracture, typically through consistent bed rest with skeletal traction through a proximal tibial pin or a distal femoral pin. When the patient is in bed, a system of pulleys, weights, and counterweights holds the leg in a certain posture to keep the bone fragments together. This procedure is known as skeletal traction. The art of femoral fracture care involves a balancing act between anatomic alignment and early functional rehabilitation of the limb, so that the surgery is indicated for the large majority of femur fractures, regardless of its location or degree of displacement, because of the high rate of union, low rate of complications, and the advantage of early fracture stabilization, which decreases morbidity and mortality. We recommend that femoral subtrochanteric fractures in polytrauma patients be repaired within 2 to 12 hours of injury, provided the patient is hemodynamically stable. Performing operative fracture repair within the first 24 hours decreases mortality, respiratory complications, multisystem organ failure, and length of hospitalization. Early surgical repair may be less important in patients with isolated closed fractures. Nevertheless, we advocate early repair. Currently, the method most surgeons use for treating subtrochanteric fractures is intramedullary nailing. During this procedure, a specially designed metal rod is inserted into the canal of the femur at the hip. The rod passes across the fracture to keep it in position. Intramedullary nailing provides strong, stable fixation. Intramedullary nailing is associated with a 99% union rate and low risk of infection, even when used in open fractures. In certain fractures where comminution is severe to an extent that an intramedullary device can actually create more fracture displacement, the blade plates and locking plates are more useful. The plates are also helpful in cases where intramedullary nails are difficult to insert, as in narrow intramedullary canal, both in cases with severe deformities, which could result in malalignment with the nail insertion, and in cases where better screw purchase and stability are required, as in paraprosthetic fractures. Besides these, the plates should always be kept as backup options for a failed intramedullary nailing procedure. During this operation, the bone fragments are first repositioned into their normal alignment. They are held together with screws and metal plates attached to the outer surface of the bone. The most successful type of plating involves the use of 95-degree fixed-angle blade plates. Another form of fixed-angle plating includes proximal femoral locking plates. In cases where there is severe injury to the muscles, nerves or arteries, or there is significant contamination with dirt, rocks or grass from the injury, some patient requires external fixation prior to definitive surgical treatment. External fixation may be used in unstable polytrauma to ensure the patient is physiologically optimized prior to definitive fixation. This is an operation where metal pins are placed into the bone above and below the fracture site through small cuts. The pins are attached to a bar outside the skin to stabilize the fracture and hold the bones in the proper position. After secondary operations to clean the wound or recovery of skin injuries, or if the patient is physiologically optimized, the external fixator can be removed and plates and intramedullary nails or plates and screws can be placed. Recovery after surgery. Postoperative activity depends upon the adequacy of internal fixation. If fixation is solid, an agile, cooperative patient can be out of bed within a few days of surgery, and ambulating on crutches with toe-touch weight bearing on the affected side. Follow-up patient visits with the orthopedic surgeon to monitor fracture healing with radiographs are generally performed at approximately 2 weeks, 6 weeks, 3 months, 6 months, and 1 year post-injury. Most femoral subtrochanteric fractures take 3 to 6 months to completely heal. Some take even longer, especially if the fracture was open, or broken into several pieces, or if the patient uses tobacco products, or if he is diabetic. Cutting down or quitting smoking and tight blood sugar control is important for the healing process. Physical therapy will help to restore normal muscle strength, joint motion, and flexibility. It can also help you manage your pain after surgery. Most patients need about 3 to 4 months of therapy to regain their pre-injury range of motion and strength. Patients usually have good ambulation within 1 month and can expect to return to normal activity within 3 to 6 months in younger patients, and up to 12 months in elderly patients. Athletes may safely return to sports when the femur is completely healed and normal strength and range of motion are regained. Most athletes return to pre-injury levels of function after approximately 9 to 12 months or longer, depending upon the complexity of the injury. The intramedullary nail usually stays in for life and are not routinely removed. However, if the metal becomes infected or is painful 1 year after surgery, it can be removed.